Hello, everyone. I'm Norman Kahn. I serve as convener of a coalition that's addressing the opioid epidemic through the education of health professionals. And I've been asked by the California Area Health Education Center to present this online webinar, which I'm really happy to do this morning. So again, this coalition has 28 organizations in medicine, nursing, dentistry, pharmacies, physician assistants, and social work. And these are the organizations. I mean, it's a long list, but you can see that there's a number of organizations in each of those disciplines. The objectives of this coalition, called the Conjoint Committee on Continuing Education, is to educate and facilitate the education of both prescribers and their practice teams in risk evaluation and mitigation strategies for opioid analgesics. Now, that phrase, risk evaluation and mitigation strategies, comes from the Food and Drug Administration, and that's because we have a unique relationship, and have since our beginning in 2011, 2012, with the FDA. But the other thing that's important about this point is that originally, the FDA was charged to educate prescribers. Risk evaluation and mitigation strategies are common. There's more than 40 of them. Accutane is probably the most well-known, where the companies that offer these products have to educate people in their dangers and risks. But the risk evaluation mitigation strategy educational program in opioid analgesics is a little different. So in 2012, and then revised in 2018, the FDA published their blueprint for educating health providers in treatment and monitoring of patients with pain. And we got involved early because the FDA turned to our coalition and said, we need somebody from the education community to help us write this blueprint, which we did. And then we reviewed and commented on it. There were very few changes in 2018. The biggest change was to include immediate release opioids as well as extended release opioids, because the original blueprint was just on extended release and long-acting opioids. The other group that's engaged are the companies that make the opioids. They call themselves the REMS program companies. The FDA turned to these companies and said, you will pool your funds through a third-party agent. In this case, the agent is called Syneos Health. And you will offer grants every year to educational providers to teach clinicians about appropriate pain management and safer opioid prescribing, using the blueprint that the education community helped develop. So this is a very unique situation. As you can see, there are a lot of companies engaged in making opioids. The FDA has turned to them and has said, you pool your money and put them out for grants. So there is a firewall between what the grant money is for and the companies. The companies put the money in, and the blueprint, which the FDA created with the education community's help, is the curriculum. There are 8 or 10 grantees that produce this education. You can get their names on the RPC website. Now, when we started back in 2012, the landscape was basically the Food and Drug Administration, and the CDC was beginning its process of publishing, which they did in 2016, their guidelines for opioid prescribing. But back in 2012, it was mostly the Food and Drug Administration. Since then, there have been quite a few agencies, both federal agencies that you can see here, also at the state level, the National Governors Association is engaged. And most recently, as of last year, the National Academy of Medicine has started an action collaborative on countering the opioid epidemic in the United States. We have a lot of hope. Most of the organizations that participate in our coalition, the Conjoint Committee, are also participating in the National Academy of Medicine effort. And we have a lot of hope for the future of that effort. Even though it says National Academy of Medicine, it's an interdisciplinary effort. All of those disciplines, except I think social work, are involved. So PAs, dentists, nurses, pharmacists, and physicians. So let's go right to the beginning. What are opioids? Now, these are pain relievers they're either natural, and like morphine, heroin, those are natural opioids, although heroin requires a bit of processing, or completely synthetic, made by man. And fentanyl is the best example of an opioid that's completely synthetic. You'll recognize many of the names in here: Vicodin, OxyContin. We'll talk about some of these. Certainly recognize codeine. It's been around for a very long time. But they all come from the poppy plant. This is the poppy plant before, the opium poppy plant, before it's opened, the flowers open. And you can see that there's a scar on this made by a razor blade, and that there's a white latex material that's dripping from the bottom of the poppy plant. This is how poppies are harvested, and how opium is made, and other naturally occurring opioids are derived from the latex. Now, if this were a plant that was harvesting these poppies, you'd see razor blade slices all around the poppy, and it dripping from every one of them, which is a more efficient way of collecting this latex. But in the latex alkaloids, there are all sorts of morphine-like derivatives. Heroin is the most historically used derivative that's processed a little bit to make this into heroin. But all of the naturally occurring opioids, let's go back a slide and take a look at them, such as hydrocodone, morphine, and codeine. All of those are made from one of these alkaloids in this latex that comes out of the poppy plant. Fentanyl, on the other hand, is made synthetically in a lab. So a little history. We are not in the first opioid crisis in the United States. There was actually an opioid epidemic, if you will, after the Civil War. And again, there may be as many as 2 million people who were using opioids after the Civil War from war injuries, and a lot of aggressive marketing and overprescribing. The painkillers at that time were different. They were laudanum, they were tincture of opium, different names, but still derived from the poppy plant. And it resulted, although it took a while, it resulted in the Harrison Narcotics Act of 1915, which basically taxed narcotics and prohibited using narcotics in the treatment of addiction. Now, we'll get back to this as there are more and more options for treating addiction, which we'll talk about later. So fast forward, that's one too many. Fast forward to the current crisis. This is a really telling slide, and this is one of the most important data points in this epidemic. Around 2009, when these two lines crossed, there was a lot of recognition that at that time, overdose deaths in the United States exceeded deaths from motor vehicle accidents. And because overdose deaths were kind of behind the scenes and motor vehicle accidents were out front, and we knew them and to some extent accepted that people were going to get killed by cars, we did not recognize how many people were dying from overdoses. And that stimulated a great deal of attention and really started the current focus in this epidemic. I have lots of slides. Some of them are busier than others, but I'm going to call your attention to a couple of lines on this one. Look at the purple line in the middle. This is natural. This is like oxycodone and hydromorphone. These are the naturally occurring, although processed, opioids. And you can see over the years how the deaths from these opioids have steadily risen. But look at the blue line right below it that crosses it in about 2014. That's heroin. And what has happened, you'll see that the purple line kind of stalled out between 2011 and 2013. This was some of the efforts, the early efforts to reduce the amount of prescription opioids out there in the marketplace. And a lot of people were turning to heroin and a lot of deaths from heroin. But look at the orange line, that very steep line since 2015, 2014. Those are synthetic opioids, and that's fentanyl by and large. And the risk here is that as people turn to heroin, during this period of time, the heroin was becoming laced with fentanyl. Fentanyl is anywhere from 10 to 50 more times more powerful than heroin. You get fentanyl, which is 10 times. You get carfentanil, which is 50 times. Sufentanil, which is maybe even more than that powerful. The addicts could not, the opioid use folks could not recognize the difference between white powders. Their They don't look any different. They don't taste any different. And so they had no idea what they were taking, and a lot of people were overdosing on their heroin dose because it was laced with fentanyl or a fentanyl analog. Another busy slide, but actually not difficult to interpret. If you just look at the top line, which is the top set of bars, which is pain relief or misuse, you can see these lines, these bars are going down. And this is the good news. Through a variety of efforts, some of them are law enforcement, some of them are public health, medication treatment, some of them are education. We're actually seeing fewer opioid deaths from prescription opioids. The bottom set of bars, however, are heroin. But also, just look at the lower right one. You'll see that in 2017, there were fewer initiates into heroin. So going back, we remember in 2013, 2014, when we had a lot of effect of reducing the amount of prescription opioids, people were turning to heroin, initiating into heroin. Now back into 2017, there are actually fewer people initiating into heroin. That's true. You can see that on the bars on the left, fewer people using heroin. But in the people on the right, there are still more deaths from heroin. Even though fewer people are using, that's due to fentanyl. That's because in the last 2 to 3 years, particularly, heroin has been laced with fentanyl, that's synthetic, inexpensive, powerful opioid that's put into the heroin. So this is a national epidemic in the United States. Approximately 78 people die every day from heroin and opioid overdoses in the United States. You'll see some different data, different statistics. I get most of my statistics from the National Survey on Drug Use and Health, sponsored by the Substance Abuse and Mental Health Services Administration. Some of my data comes from SAMHSA, and a couple of slides come from a private source. But you can get really good data from the National Survey on Drug Use and Health. It's particularly a problem in the United States. We're going to see a couple of slides. We have 5% of the world's population, but we use 80% of the world's opioid painkillers. And here's another example, seeing how much the US uses. Canada is second, then Germany, and then it drops significantly in other countries. So this is a bigger problem in the United States. This slide I love. Don't be alarmed by the busyness of this slide. I'm going to call your attention to it. If there were any slides I want you to remember, this is one of them. Just look at those gray bars there on the side of each of the groups. That gray bar means that people gave other people for free an opioid. This is the sources of prescription opioids. So that by far, in a way, the largest number of opioids out there are given to people. The red bar is prescribed. So you might go to a doctor and get it. And then the green bar next to it is stolen from a friend or bought from a friend is the next one. Those are all in there, but by and large, giving people opioids is the number one way that opioids get around in the system. So this requires us to do a significant amount of education of prescribers and their practice teams, not only on how much to prescribe, so there's less out there, but also safe use and safe storage of opioids so that people aren't tempted to give some away or people aren't tempted to come in and get some. So how did we get into this crisis in the United States? I've got 3 slides that will give us 3 data points, 1 from 1980 and 2 from 1995. So back in 1980, this little letter to the editor, and this is the whole letter, by the way, this is not redacted, this is the entire letter, just a tiny little letter, was sent to the New England Journal of Medicine and published. And basically, there were some physicians who were just trying to share their experience and shared that in their experience with hospitalized patients, not very many of them got addicted. That's just one data point. It's not even a study. It's just a letter to the editor sharing the experience of a group of physicians. As it turns out, this little letter was referred to by physicians for many, many years thereafter. It had a lot more impact than its little size. And it helped to portray the sense that opioids may not be as addictive as we'd feared. Then in 1995, the American Pain Society introduced this concept of pain as the fifth vital sign, but it was important that it was adopted by the Joint Commission on Accreditation of Healthcare Organizations, and by the way, by the Veterans Administration in the late 1990s. And the other vital signs, of course, are pulse, temperature, respirations, and blood pressure, so that everybody's pain level was supposed to be measured like their pulse and their temperature when they came in to see a clinician, and really promoted this idea that if you had pain, it should be dealt with, and started to help us along the path of having a sense that maybe pain wasn't necessary and maybe all pain should be treated. Interestingly, this sense that pain was the fifth vital sign was what lasted until January 1st, 2018, before the Joint Commission on Accreditation of Healthcare Organizations removed this from their questionnaires. However, the Center for Medicare and Medicaid Services still uses the HCAPS. Okay, if I can remember what HCAP stands for, the AHRQ system of patient sense of how good the care that they're getting, patient evaluations and patient scores in the hospital. Hospital Consumer Assessment of Healthcare Provider and Systems is what HCAP stands for. That is still a question in the HCAP scores, so that we still have some way to go. So, of course, the other thing that happened in the mid-1990s was that oxycodone, OxyContin was approved. This is Purdue Pharma's product. Of course, you saw that there are 65 companies that make opioids, so there are a lot more products than these. But I think we all recognize the term OxyContin, the name, the brand name. It was really marketed. Of course, Purdue Pharma has been sued, as have some other companies, Insys, a couple of others. Many other lawsuits are pending. And a lot of those lawsuits are about false advertising, over promoting the drugs, paying physicians to prescribe them through lucrative speaking fees, etc., but also marketing them as less addictive than they actually were. So those are three of the points that enabled us to get into this crisis: the 1980 publication, the 1995 pain is the fifth vital sign, and then the introduction of OxyContin and others into the market. So as we increase the number of opioids in the market, we increase the opioid deaths. As you can see, there's a pretty straight correlation here between the number of opioids available and the number of deaths from opioids. And they generally started with a prescription. So heroin, most heroin users, 2 out of 3 heroin users start with a prescription painkiller. What are the interventions? We've seen now a little history and how we got into this crisis, and we know that the more opioids we have out there, the more deaths there are going to be. So just what are the interventions? And I would share with you that are really 3 classes of interventions. There's law enforcement. This started with closing pill mills. This was maybe 5-6 years ago, starting in Florida. Of course, what happened with a pill mill is a prescribing site in which that's all they do is prescribe opioids for money. They're really not a good faith evaluation and management of patients with pain or patients with other settings. They're just places to go and get a prescription for an opioid. Most of those were closed in Florida. They moved to adjoining states like Georgia, but over the last several years, lots and lots of these pill mills have been closed. There have also been some disciplining of individual prescribers, and I'll show you a slide on that in just a minute. So the second category of interventions are public health interventions. One is the availability of naloxone, and I've got 1 or 2 slides on that. And then this concept of medication-assisted, or now called medication-based treatment. I go all the way back to the Harrison Narcotics Act in 1915, which prohibited the use of opioids for the treatment of opioid use disorder. Well, in medication-assisted and medication-based treatment, indeed, we do use opioids for the treatment of opioid use disorder, but they're different. We'll talk about that. And then the third category is what our coalition does, the Conjoint Committee on Continuing Education, which is facilitate the education of prescribers. The education is actually done by the grantees, but also the health professional team members. And we'll talk about how well that's gone. At the moment, the coalition is discussing educating the public, the Surgeon General's Office, the National Institute on Drug Abuse, the Substance Abuse and Mental Health Association, Services Association Agency, are very interested in public education as well, and we've been working with them on looking at how to do public education in the future. So I told you I'd share with you a few examples of enforcement. These are actual physicians. These are all online. It's public information. I just gave you initials instead of names, but you can get names of these folks online. And then there's this recent one you probably heard about. This is being recorded in June of 2019. Earlier this spring, there was this big Appalachian Regional Prescription Opioid Strike Force. Another 30 or so clinicians were arrested and disciplined for overprescribing. Now, the Drug Enforcement Administration, which licenses people to prescribe, has a model that there are, in their view, 4 different reasons why people might overprescribe. One is that people are simply out of date. They haven't been educated. They haven't taken the REMS blueprint compliant education. They haven't educated themselves on prescribing. They prescribe too much. They prescribe too often. They're just out of date. There are some who are fooled. Some of the people with opioid use disorder are very clever. Of course, prescription drug monitoring programs have really slowed this process because now any prescriber in almost any state can get information about who might be doctor shopping for opioids. There are physicians and other clinicians who prescribe who are simply disabled, some of them disabled on opioids themselves. And then there are very few who are dishonest, and these are the ones that are picked up in the law enforcement raids and in the pill mills. This is a map of prescription drug monitoring programs. Almost all states have prescription drug monitoring programs. Actually, all of them have some kind of a prescription drug monitoring program. Not all of them talk to each other. I happen to live in Kansas City, and so I'm right on the border with Missouri. You can see Missouri there in the center. Missouri does not have a statewide prescription drug monitoring program, but regions within the state do. There's a lot of challenge in interactivity of these prescription drug monitoring programs. The idea, of course, and the way that it works is, if you're a prescriber, you can seek out your state's prescription drug monitoring program and find out if people are doctor shopping, or if the person in front of you is just going to you and nobody else, which may have make a big difference to you in your prescribing habits. But there's just not a lot of good communication, particularly in Kansas City, where Kansas doesn't talk to Missouri and parts of Missouri don't talk to other parts of Missouri. So what is the evidence? Should we be prescribing these at all? Chronic pain, which is what extended release and long-acting opioids are for, is an interesting phenomenon, and we need to look at the indications. So there are a few indications for prescribing opioids. The first is end-of-life care. A lot of people recognize this. Somebody may be on a morphine pump. I don't think anybody takes any issue with end-of-life care. Then there's palliative care, which is not the same. Palliative care, best example is I met a person who's actually a leader in the opioid epidemic, leader in addressing it, who is a health professional herself, who has severe rheumatoid arthritis. She has a long lifespan, but she is managed on a variety of medications, of which opioids are part of her management plan to palliate her pain. Chronic cancer pain would seem to make sense. The reason that I put CDC in parentheses here is that recently the CDC had to clarify that they really did mean that chronic cancer pain was an indication. And the reason is that states, in their attempts to deal with the opioid epidemic on a state level, many states have passed laws that will limit the amount of opioid that can be prescribed, which has had a significant impact on people who may be taking a lot of opioid, 100 morphine milliequivalents a day or more for chronic cancer pain. And a state that passes a law that says that you will not prescribe more than 90 really affects people in this category. So the CDC came out with a clarification. No, they didn't mean that you should take people off of their chronic opioids if they're in chronic cancer pain. Acute injury, we've all seen movies where people are out on the battlefield and the medic shoots a morphine plunger into the injured soldier and so on. The real question comes up in surgery. I'll give you some examples. One of them is my own example of having had a minor surgical procedure a couple of years ago and getting 30 hydrocodones prescribed, which I did not fill. It only took me about a day and a half of a non-steroidal anti-inflammatory to cover my pain. I went back and told the surgeon in my follow-up visit, and he said he had not recognized that he had prescribed 30. It must be a standing order or something, and of course the system learned from that. But there are other acute pains like renal colic, in which certainly on the short term, that kind of pain is certainly an indication in many cases for an opioid. The real question comes up here for having your third molars removed, your wisdom teeth, or other surgical procedures. There's getting to be more and more evidence in the literature that, for example, for third molar removal, it probably isn't necessary in most cases. And so, therefore, people are really cautioned against using opioids in that situation. But people have to use their judgment in prescribing for other post-surgery. This is, however, a really critical category down here. I've separated from the above categories because these are people who may not, probably not, maybe not, should have been on an opioid to begin with, but have been. This is non-cancer pain, chronic pain, low back pain is an example, others in which people have been on stable, high doses, long-term. Very reliable patients. They don't doctor shop. They get their prescription from you only. They don't increase their dosage. They don't lose their pills. The dog doesn't eat their pills. But these are folks who are perhaps have been tried to taper without success, have been recommended to medication assistant and hasn't worked for them, or they haven't been able to do it, or they live in a community in which it's not available, which is about 80% of the time. Approximately 20% of people who could benefit from medication-assisted treatment are actually getting it. So these are people who maybe shouldn't have been on an opioid to begin with and maybe on very high doses, but they're stable and reliable and they need to stay on it. And that has the FDA in parentheses there because the FDA recently clarified that, yes, indeed, they did mean these people. These are people who take extended release and long-acting opioids. So here's the CDC guidelines. There are many, many pages of these. I only am giving you one slide. There's a link at the bottom where you can get them. These are really a good way to understand what the indications are for prescribing opioids, when to initiate, how to choose one, assessing the risks and harms of opioid use. This is probably the gold standard for prescribing guidelines for opioids. They were published in 2016. And while there have been a couple of clarifications, as I mentioned on the previous slide, they're still valid. So there are other medicines besides opioids for chronic pain. There are non-steroidal anti-inflammatories and acetaminophen used either separately or alternately. Very effective, lots of literature that shows that these are effective in post-surgery, in wisdom teeth removal, lots of other situations. There are a number of adjuvant medications, and this is where it gets a little complicated. I shared this slide with a friend of a friend who has a family history of addiction and didn't want to start on an opioid, even though he has chronic pain. And his friend referred him to me, and I sent him this slide to go take to his clinician, his doctor, his other prescriber, and say, what else can I use besides an opioid? At the bottom, you'll see that there is just recently, just in the last few weeks, the approval of a new medication, lofexidine, for, quote, mitigation of withdrawal symptoms to facilitate abrupt discontinuation of opioids in adults to keep them from going into withdrawal in a way that would not be successful. This drug is new, it's expensive, it's chemically related to clonidine, which has been on the market for a long time, which is much less expensive, but that's the category that lofexidine falls into. So in addition to medications, people always ask, what else can I do besides medications? There are lots of choices. Cognitive behavioral therapy has been proven. Physical therapy, very common. Various complementary and alternative medicines, acupuncture, nutritional consultation, lifestyle changes. You know, these are all subject to, some of them are subject to randomized controlled trials, and some of them are just N of one, meaning if you use it on a person and it works, go with it. So this is the first of two interactive questions. I know that this is not really interactive, but you all are out there. And so the question to you is, would you consider implementing an intervention that could be shown to do the things that are popping in and out on this particular slide? So let's go back and see what these interventions are. Increasing retention in treatment, decreasing time, increasing length of life, those things. The answer, of course, in this case is yes, we would consider an intervention. And this is the treatment for opioid use disorder with medication-assisted treatment, or what's now called medication-based treatment. Methadone has been around the longest. Methadone has some real advantages. It's long-acting. It's a full agonist, meaning it goes in there into the mu receptors that all the other drugs, the opioid drugs, do too. And if you took enough, it could make you high. The real risk of methadone is that if you take that much, you're likely to overdose. So that's why it's given in methadone clinics, day at a time. The big disadvantage, of course, is that people have to go to a methadone clinic, and it takes a long time in a methadone clinic before people trust you enough to give you a day or two's worth, take home over the weekend, and not overdose on or share. So you have to take it in a methadone clinic, but its data is really excellent. People that are on methadone do succeed in all of these things that were on this previous slide. If I can get them up again. Methadone results in these outcomes. Buprenorphine is newer. You have to have a specific waiver. You can prescribe it in your office, but you have to have a specific waiver. So it's an 8-hour program to get this waiver, and then there are limits, 75, then eventually 200 patients that you can prescribe for. The advantage of buprenorphine is that people can take it home. You can even initiate people at home if you know them well and you're confident that they can initiate buprenorphine treatment. That's a whole nother lecture. And then there's injectable, a month-long extended release naltrexone. Methadone's a full agonist. Buprenorphine is a partial agonist, which means it goes in there. You don't get high from buprenorphine. It blocks the mu receptors. And then naltrexone is an antagonist. So this is a little bit like the medications, like a trade name drug called Antabuse for alcohol, which is that if you drink alcohol while you're on Antabuse, you're going to get sick. And if you use while you're on naltrexone, you're going to be unhappy and unpleasant because it's an antagonist, not an agonist. So here they are again, these three. Naltrexone blocks the effects of opioid. Buprenorphine activates the opioid receptors without making you high, and methadone fully replaces the effect of whatever medication the person has been taking. All three are useful. The data for methadone and buprenorphine is more extensive than the data for naltrexone, which is a newer drug. But this is medication-assisted treatment, now sometimes called medication-based treatment. Only 20% of opioid users who need this treatment are currently getting it. We'll come back to that. So here's some other public health interventions. Naloxone, the most common trade name is Narcan, now available in a nasal spray. This is a lifesaver. So there's a number of states that will permit pharmacies to sell Narcan, naloxone without a prescription. It's not that hard to use. If an overdose is witnessed, you can save someone's life. But there are a couple of things you need to know. It takes a little while to affect. It only stays in the system for an hour. So you can't just give somebody Narcan and wake them up and then leave them, because an hour later they could go back into their overdose, because the half-life of naloxone is shorter than the half-life of the opioid. 40% of overdoses are witnessed, but rarely is Narcan available. So the more that we get naloxone available, the fewer deaths there will be. I'll just tell you a quick story. I was taking a walk through the District of Columbia last fall, and I went into a firehouse where they had a museum. And one of the firemen there gave me a tour, and I happened to ask him if I told him what I did and the coalition that I convened, and asked him if naloxone was available in their ambulances. And he told me at that time, this is October 2018, he told me that half of the dozen ambulance houses in Washington were permitted to use naloxone. I'm happy to say that as of June of this year, they're all able to use naloxone. This is a naloxone auto-injector, which is very easy to use and comes with instructions. Any one layperson could use it. It's similarly life-saving. Both of these medications, naloxone, trade name Narcan, and this injector, trade name Evzio, are more expensive than they used to be, and in some cases significantly more expensive. It's just one of the barriers, unfortunately, to their use. But it's important to know that these are available, they're easy to use by lay people, and they're life-saving. So here's the second question on, would you consider implementing an intervention? We saw the first one was medication-assisted treatment. We all agree that it's useful, that it's working, that it's saving lives. So here's another intervention which can reduce the deaths from overdoses. Reduces syringe sharing, increases safer injection behaviors, increases the use of addiction treatment, both referral and retention into medication-assisted treatment, so you can get these people into medication-assisted treatment and off street drugs. Reductions in violence against women, reductions in public disorder, does not have any changes in community drug use patterns, does not initiate injection drug use, does not increase drug-related crime, promotes effective public health and police partnerships, and is cost-effective. This is a much more controversial intervention. All of these, you see the references there. There are 11 countries that now permit supervised injection facilities. The United States does not. It's still illegal in the United States. It has been tried in the United States. There was a recent example of one in a state in which it was being tried, but there was pressure on the legislature to close it because it gave people the impression that the state government was aiding and abetting addiction, which is one of the stigmas that we're going to talk about toward the end. So this is facilities where people may go to consume drugs that they obtain elsewhere. They don't get the drugs there, in a hygienic environment with appropriate supervision and equipment without fear of arrest under trained supervision. So you need to know that the coalition that I represent does not have a position. It's never discussed supervised injection facilities. I'm using this personally in this slide just to give you a sense of the scope of this epidemic and what people are doing about it. So here's an example of the site in British Columbia in Canada, one of the 11 countries in which it is legal and from which the data over the last several years has been drawn. You can see what happens here. It's not that there aren't overdoses here. It's that people are there with naloxone to revive them and get them back to life. So in this particular one in Insight in Vancouver, there have been no deaths from opioid overdoses. So these are people who are going to use anyway. They come in and do it here. Not all of the supervised injection facilities do needle exchange. This one does. But it's very controversial. It just depends on whether or not we want these outcomes. And if we want these outcomes, then an evidence-based review of these outcomes would suggest to us that we should consider a supervised injection facility. And indeed, there are states and locales in the United States right now that are considering these based on the evidence from other countries. So we'll get close to the end here. We're going to talk about the third category of intervention. The first was law enforcement. The second one was public health and medical treatment. And the third category is education, in this case, clinician education. So let's talk about some quality educational activities for clinicians. Those of you that are watching this, many, if not most of you, are clinicians. You need to know that there's lots of opportunity to go online and get education, particularly the education that we're engaged in, which is the FDA's Blueprint. It's a 2 to 3 hour online program. Lots and lots of people do this online, but they don't always complete it. Whereas if you do it live, you're more likely to complete it because you're a captive audience. The programs that we facilitate are based on the FDA's Blueprint. And we'll see this in another slide. What's interesting is that these are the programs that physicians usually take. Other health professions often will, like pharmacy in particular, will take education on opioids that is from a different perspective, not the FDA Blueprint. We'll talk a little bit about tailoring it. But the most important thing I think you need to know on this slide is that the education that is FDA Blueprint compliant, FDA REMS compliant, that's offered through accredited providers, we nationally, through the accreditors, measure the increases in knowledge, measure the changes in practice behaviors that are linked to improved outcomes. So there's a lot of good growing evidence that these are valuable educational activities. This is a summary slide. There's a lot of data behind this. One or two of you reading this will say, Norm, where is that data that you've got behind this? It's just too busy a slide, but suffice it to say that these are people who have completed FDA Blueprint compliant or REMS compliant, that 2 to 3 hour online or live program. Here we have 442,000 physicians. We should also state that this data is approximately a year old. We will have new data at the end of July, but we didn't want to wait to do this webinar, so we're using last year's data. Most of the physicians are doing FDA REMS compliant education, that 2 to 3 hour course. In nursing, and particularly in pharmacy, there are over 100,000 pharmacists that have taken opioid education, but it's just not the FDA compliant, Blueprint compliant education. It may be done by their health system or by the other groups that are accredited by the Accreditation Council on Pharmacy Education. But these are the numbers for people that are doing the FDA Blueprint compliant education. There's a lot of controversy about whether we should require it. There are 28 states that mandate content-specific continuing education in a variety of topics, of which pain management, actually, I forgot to change this slide. It's actually 26 states now that mandate some amount of education in pain management, or in particular, opioid prescribing. We've done literature reviews in medicine, nursing, pharmacy, and have found no evidence in the published peer-reviewed literature that mandatory continuing education increases learning or practice behavior change. You would think that it should, and of course, the 26 states that require it are trying to do something in their state appropriately, and they can pass a law requiring clinicians to have this education without recognizing that it's not an evidence-based intervention. If, on the other hand, you wanted to count the number of people who got the education, then by all means, mandatory education is valuable. But if you want to show evidence of learning or practice behavior change, then you want to have people who are voluntarily taking it, who identify a needs assessment on their own or a practice gap. Now, there's one very important study that was published in 2003 in the nursing literature, which asked about what happens with nurses who are required to take some kind of continuing education. At the time, it wasn't opioid, but it was any mandatory continuing education. And what the study found, which is done by the American Nurses Association and the American Nurses Credentialing Center, is that indeed the nurses would take the education. But because nurses had limited resources, both time and money, for their continuing education, it would prioritize what they were taking, which was required, instead of what they identified themselves that they needed in their own practice. So it diverted education from what they prioritized as their need. We're moving in 2019 into a new model. The FDA has approved the model of adaptive learning. So the companies that are pooling their money and putting out grants for FDA blueprint compliant continuing education are now, as of 2019, the grants were awarded in late 2018 and the programs are coming out in 2019. Adaptive learning is a model in which you're tested first. I'm going to, again, give you a personal example. I'm a family physician, so I participate in ongoing certification. And part of the ongoing certification is knowledge self-assessment. So I take a 60-question test, and as soon as I'm finished with the test, I'm presented with the questions that I got right. People do more of what you tell them they do well, and the ones I got wrong. And then I'm offered an opportunity to get some education and come back and try the ones that I got wrong. I'm given some tips on what the right answers might be, and eventually I have to pass a threshold, in my case 80%. It's an arbitrary number. But I can tell you that by the time you get 48 of the 60 questions correct, and you've got a dozen questions that you've tried to answer twice and they're still wrong, and you have all the right answers in front of you, you go find out what they are. So this is a very powerful learning tool. It's now going to be used in opioid education, but it also personalizes the education to the specific needs assessment and gap analysis of every individual who takes it. So it's a very personalized learning design, and it's very popular. We expect this to really enhance the attractiveness of education in appropriate pain management and safer opioid prescribing. So just a couple of slides left. This is a really important one, and this is the issue of stigma. Stigma is defined as an unconscious bias. It's got a historical definition as a mark of disgrace, shame, or discredit. So if I have a stigma, I carry a stigma with me, it's not something that I'm proud of. And this stigma can be attached to users or prescribers. So let's take a look at prescribers. If I'm known as a, quote, opioid prescriber in my community, I may perceive that as a stigma, or the community may perceive that as a stigma. I may not want that stigma, and therefore I may not prescribe opioids. I may choose not to prescribe them at all, which decreases access to pain medication for people who really need it. If, on the other hand, I know that I am prescribing for accepted indications, I can feel much better about who I am as an opioid prescriber and deal with the stigma. The stigma may still be there, however, in the community, and we need to be aware of that. Medication-assisted treatment. Some people consider that just substituting one drug or one addiction for another. Remember, medication-assisted treatment is methadone. Methadone is an opioid. Buprenorphine is an opioid. Naltrexone is an opioid. But they don't make you high, and they allow you to get back to work and to have your family back and to do all the things you need to do in society. They also allow you the opportunity to taper and get off, but even if you can't, people who go at 5:30 in the morning to an opioid clinic and get their daily opioid dose and then go on about their lives, not telling anybody that they're on methadone, they're back in normal society. So it's very effective, but it is certainly at this early stage in our addressing the epidemic, it is certainly part of the stigma. And then, of course, there's the stigma on patients. Patients who are taking an opioid for chronic pain, now they are made to feel like pariahs. Some states will even say you're not allowed by law to take as much medicine as you need. The phrase substance abuser, I don't think I've used that phrase. I've used substance use disorder or opioid use disorder, but I don't think I've used the phrase substance abuser because there's so much stigma associated with that. And even the phrase addiction, although it's a commonly used term, we're now trying to use the phrase opioid use disorder. The stigma on addiction is that people are making bad choices. That's all a choice, that they have some kind of character flaw. Their behavior is sociopathic or of course, criminal. And there's a tremendous stigma on that. But opioid addiction, opioid use disorder needs to be seen as a life-threatening illness. This is a chronic illness, a chronic brain disease. It's the structure and function of the brain, the mu receptors, the chemicals in the brain, and even the structure of the mu receptors are changed through chronic opioid use. So it is not a choice for certain. The choice for opioid addicts opioid users is to use the opioid or to withdraw. And withdrawal is not only dangerous, but can be life-threatening. It is the role of health professionals to assess and treat patients with opioid use disorder. So read this last line on this slide again to help us overcome, for both patients and providers, clinicians, the stigma against opioid prescription. Opioid addiction, opioid use disorder is a life-threatening illness. It is a chronic disease, a chronic brain disease, and it is our role as health professionals to assess and treat these patients. So, second to the last slide, if you're in a setting where you're part of the 80%, where you really don't have access to medication-assisted treatment, you don't really know that your organization, you might be in a community health center or other group where you can't prescribe buprenorphine. SAMHSA and HRSA have promoted this concept of screening, brief intervention, and referral to treatment. So screening is basically assessing the patient, asking if they have risky substance use behaviors. There are standardized tools and just asking the questions, and you can immediately on screening assess the severity of their substance use. You can then briefly intervene, which engages them in the conversation. The first step in cognitive behavioral therapy, if you will, focusing on helping them have insight and get out of denial that it's a very dangerous situation. Approximately 1.4% of folks with opioid use disorder will die each year. Some groups much higher than others. The criminals who are leaving, rehabilitated folks that have been leaving incarceration, people who are getting out of jail or out of prison, are 12 times more likely to die of an overdose because they are substance free and they'll go back to use their usual dose. It may be laced with fentanyl or not, and they'll overdose. So a lot of intervention and then referral to treatment. So find out where your methadone clinic is, find out where your buprenorphine providers are, and refer them. One of the statistics that came from the supervised injection facilities in Canada, for example, is that as many as 60% of the people who are referred to medication-assisted treatment will go, and approximately 40% will succeed. Those are huge statistics. You can do this. We'll have to decide what else we can do. There's lots of ways to prescribe. There's lots of interventions to reduce the amount of opioid that's present in the community. We're having some success. There's a lot more to do. Approximately one person dies from an opioid overdose every 19 minutes. So we've lost 3 more people in the United States just while we've been participating in this webinar. I really want to wish you the very best, no matter what your role is. This is an important effort that we're all engaged in, and we should always be coming away from situations like this asking, what else can we do? In my environment, what else can I do? We're all in this together. Thank you very much. Good luck.